Good morning and welcome. I am Dr. Rijo Matthew. I am the Chief Radiologist at Amma Scan Center for Diagnosis, Kochi. Today we are going to talk on the subject TIFFA, T-I-F-F-A. And what do you mean by TIFFA scan? When an anomaly is missed after an anomaly scan, have you ever thought what could be the reasons why we have missed that lesion? There are n number of excuses for that. One of the excuses can be the fetal position was not favorable, so that I was not able to evaluate all the organs effectively. Or we did not examine the baby at different intervals. Maybe the anomaly scan was done at a particular period, but this anomaly developed at a later period. Or the liquor was significantly less. So all these excuses are there, but the fundamental problem with missing of lesions in an anomaly scan is most of the people who do an anomaly scan do not consider it as a whole body scan. It's actually from the baby's head to toe you need to evaluate and look for all structural anomalies. So basically we need to redefine anomaly scans. Anomaly scan is a whole body scan. And with the new technologies that are developed, especially with the high resolution imaging and the concept of volume imaging, the 4D scans, it is possible now to do a whole body anomaly scan. But it requires dedicated approach, and we may require serial evaluations as the fetal development is a dynamic process. So what is TIFFA? It is targeted imaging for fetal anomalies. It's an organ-specific targeted scan. We have got a fetal neurosonogram looking into the different structural anomalies of the fetal brain and spine. We got the fetal echo, the evaluation of the fetal heart, the fetal urosonogram, the evaluation of the fetal kidneys, ureters and bladder, the musculoskeletal survey of the fetus, the evaluation of the facial dysmorphism, the fetal face evaluated frontally and in profile views. Apart from this organ-specific targeted imaging, we need to evaluate for the genetic markers, and also has to assess the biophysical profile and a functional evaluation of the fetus can be done. For example, a gastric emptying, a bladder emptying, these can give vital clues about the function of that organ. Apart from organ-specific targeted scans, evaluation of genetic markers, biophysical assessment, we have to evaluate the fetal environment. Look for the placenta, the umbilical cord and the liquor. And also the monitoring of the blood flow within these structures, which can give vital clues about the fetal environment and the fetal well-being. So in short, targeted imaging for fetal anomalies covers all these things. It's an organ-specific targeted approach. You have to evaluate the genetic markers, you have to have a biophysical profile and assessment of the fetal environment. What are the tools and keys for TIFFA? The first and fundamental is a high-resolution two-dimensional scan. Nowadays, the resolutions of the scans have improved so much that the clarity is astonishing. And we can use the 3D and 4D scan for multiplanar evaluation and reconstruction. There are different rendering modes and different techniques like STIC, the spatial temporal image correlation, the multi-slicing, etc. that can be vital and very important in the evaluation of the fetus. The targeted organ-specific dedicated approach is a must, and serial evaluation of the fetus at different intervals is another important tool. These are the quality of images that are now possible with the high-resolution scanners that are now available in the market. You can evaluate the choroid plexus, you can see the magnified image of the fetal head there on the left side, and a 8-week, 9-week fetus seen in full view with the amnion around it is seen on the right side. Another important tool in the evaluation in TIFFA is the use of 3-dimensional and 4-dimensional images, 3D and 4D scans. What we were seeing in the 2-dimensional imaging were sliced images. We were seeing the sectional images, the planar images. But the human body being a 3-dimensional structure, we need to evaluate the body in all the 3 dimensions. And it is now possible with the 4D scan. Many people ask the question, why do we require a 4D scan in the evaluation in ultrasound? From a radiologist's point of view, I can tell you that that is the future and that is what is being practiced now. If you take it in MRI or CT, especially the multi-scanner, multiplanar CT, the multi-slice CT, we evaluate all the structures in the coronal plane, sagittal plane and the axial planes, and also do a reconstruction of the structure. So that is nothing new for a radiologist to evaluate a structure in all the 3 planes and see the 3D reconstructions. Naturally, in ultrasound, when with the 4D scan, it is another logical extension of that approach, and we need to utilize that approach in ultrasound, especially in TIFFA scans. That is the concept of volume imaging. It's the volume that is being imaged, the structure of interest, the whole data is being evaluated, and it requires a proper acquisition of the image. The 3D image has to be acquired, then displayed in different rendering modes. There are different rendering modes like surface rendering, maximum intensity projection, minimum intensity projection, inversion mode, the volume contrast imaging, etc. The multiplanar images helps you to analyze a structure of interest, and especially with the new softwares like Sono VCAD, it is made, and Sono NT, etc. The life is made much more easier for the imaging specialists. These are some of the examples of the rendering modes that are available, and with the different rendering modes, the anomalies can be very clearly depicted, and at the same time can be shown to the parents as well as the referring doctor. A clubfoot, bilateral clubfoot is shown in the middle, and a case of autocephaly is shown on the right side. Among the different rendering modes, there are rendering modes that can show the skeletal structures very well, especially the maximum intensity projection. The fluid field structures very well in minimum intensity projection. And these approaches can be made use of in fetal neurosonograms. Like the corpus callosum can be seen here very clearly in a sagittal section. This is a volume contrast imaging, VCI section, that clearly shows the entire genu, body, splenium of the corpus callosum. In the basic examination of fetal CNS, there are only these 2 views that are important, that is transventricular and transcerebellar view. But is that enough? We need to evaluate the corpus callosum, we need to evaluate the cerebellar, vermis, and much more structures. So, in a fetal neurosonogram, a sagittal section that can show you the corpus callosum, the sulci and gyri at later stages of pregnancy, the interhemispheric fissures, and the evaluation in the coronal plane is all important for a proper and a dedicated fetal neurosonogram. When compared with the fetal MRI, this approach, especially with the 4D scan, the evaluation in the coronal and the sagittal plane with the high resolution scanners nowadays available, it's almost comparable. So why don't we make use of that modality? And especially another important tool is tomographic ultrasound imaging, multi-slicing. Just like you see in CT and MRI, you can evaluate a structure in different thickness, different sectional intervals, maybe 1.5 millimeter, 1.2 millimeter. You can evaluate that structure, just like what we do with CT and MR. These are some of the examples of a fetal neurosonogram, the sagittal and axial images. Another important area that has to be evaluated is fetal heart. A dedicated approach for the evaluation of fetal heart is a must, because fetal heart anomalies are very common, and there are certain anomalies if detected early and properly and can be corrected by either by surgery, corrected by surgery if properly delivered in tertiary centers. So in fetal echo, we need to look for the high abdominal view, four-chamber view, the left ventricular outflow tract, right ventricular outflow tract, that is the outlet outflow tract views, the three-vessel view, the ductal and the aortic arch. So these views can be very clearly evaluated with new technologies like spatial temporal image correlation, that's 4D stick. A 3D acquisition of the fetal heart and a display of these structures is possible with the Sono V card. New softwares like Sono V card automatically displays all these sections of interest in fetal echo. So in my experience when we use the 4D stick and the tomographic ultrasound imaging, fetal echo is made relatively easy. You can evaluate the four-chamber view and the outlet tract views and all the necessary views for a fetal echo within no time after you acquire the three-dimensional image of the fetal heart. Another area that needs to be evaluated thoroughly is the fetal KUB, the fetal urosonogram. This is one of the example of a post-urethral valve showing the keyhole sign and with the dilated dilated renal pelvis and the ureters. Musculoskeletal survey is possible easily. You can count the number of ribs, you can evaluate the vertebra, you can look for the spina bifida, and the facial dysmorphism evaluation. Look for the sutures, nasal bone, the orbits. We can evaluate a hypotelorism or a hypertelorism. Look for micrognathia. Look for the ears. So a facial dysmorphism evaluation in frontal and profile side views can be very helpful, can be a vital clue in the evaluation of certain syndromes. These are some of the examples of cleft lip and cleft palate, especially with the use of the new rendering modes with 4D. Some limb abnormalities are shown here. Another area that needs to be discussed, that needs to be utilized in a TIFFA scan is genetic sonogram, the evaluation of the genetic markers. Some of the subtle markers can lead to the diagnosis of severe chromosomal abnormalities. The nuchal fold thickness, which is important in 14 to 22 weeks. Nuchal translucency is important in 11 to 14 weeks. You need to understand the difference between nuchal translucency and nuchal fold thickness. The nuchal fold thickness is measured in the sagittal section with the proper magnification, and it is measured in 11 to 14 weeks, whereas nuchal fold thickness is relevant from 14 to 22 weeks. Echogenic intracardiac focus is shown on the right side, which is considered as a minor chromosomal marker. Absent nasal bone is again a chromosomal marker. But apart from these markers, there are n number of chromosomal markers, but important ones are, especially in 11 to 14 weeks, the nuchal translucency, nasal bone, the tricuspid insufficiency, and the reversal of ductus venosus. Reversal of diastole in ductus venosus. The minor chromosomal markers include the renal pelvis dilatation, often called as the pilectasis, the echogenic intracardiac foci, echogenic bowel, choroid plexus cyst, etc. So in a TIFFA scan, we need to have an organ-specific dedicated approach. We have to evaluate the neurosonogram, the urosonogram, fetal echo, the musculoskeletal evaluation, the facial dysmorphism evaluation, and also the evaluation of genetic markers. You need to develop a